Right. Good afternoon and welcome, everyone. My name is Brian Ward from the Division of Healthcare Statistics here at the National Center for Health Statistics. A few notes just to get started today. Currently, all participants and attendees in the webinar are in listen-only mode. Today's webinar is also being recorded, so if you have any objections to this, you could disconnect at this time. And finally, for anyone needing closed captioning services, a link will be placed in the chat that you can use to access those. All right, so on behalf of all of us in the Division of Healthcare Statistics, I wanted to say thank you for taking the time out of your day to join us today. Myself and my colleague, Dr. Jill Ashman, will be discussing recent developments, details, and products from the National Ambulatory Medical Care Survey Health Center component. Any questions or comments you may have may be entered through the Zoom Q&A box, and we'll address these as time permits during the question and answer sessions that will follow the formal presentation. Next slide, please. Right, as for the agenda today, first we're going to start by discussing the background and recent modernization efforts for the National Ambulatory Medical Care Survey, or NAMCS as we'll refer to it throughout the presentation. We'll then speak specifically about the survey's health center component, providing details on the redesign. Finally, we'll be discussing the resulting data and resources from the NAMCS health center component, and then talk a little bit about its future plans. Next slide, please. All right, a little bit on the background. NAMCS is part of the National Healthcare Surveys program. The goal of our national healthcare surveys is to produce accurate, objective, and nationally representative statistics on healthcare to inform policy and research. Collectively, these surveys cover a number of healthcare settings, from ambulatory and hospital care to post-acute and long-term care. Unlike some of our other surveys here at the National Center for Health Statistics, our healthcare surveys are establishment surveys, not household surveys. Thus, the resulting data provide estimates about the universe of encounters with providers and not the U.S. population. Historically, for our surveys, patient-level data was manually abstracted from medical and administrative data records. However, we have recently moved to use electronic health records, or EHRs, for data collection. This has been a major change for our surveys and has resulted in data from a much larger number of medical visits. Next slide, please. So the diagram in this slide provides a high-level overview of our national healthcare surveys, highlight not only the data collected by these surveys, but just to see where NAMCS fits. As for the ambulatory and hospital care surveys, data from physicians and provider offices, as well as health centers, have been collected by NAMCS. We also conduct the National Electronic Health Records Survey, where physician-level data are collected on the adoption and use of EHRs. As for the hospital care setting, historically the National Hospital Discharge Survey collected inpatient data, while our National Hospital Ambulatory Medical Care Survey, which just recently ended in 2022, collected data from visits to emergency and outpatient departments, as well as ambulatory surgery locations. These both paved the way for our current National Hospital Care Survey, which collects data from inpatient departments as well as emergency departments. As for post-acute and long-term care, 5 sectors of care, including residential care, adult day services, nursing homes, home health, and hospice care, were collected through the National Study of Long-Term Care Providers. Data from inpatient rehab facilities and long-term care hospitals were later included, and our current National Post-Acute and Long-Term Care Study now has data from all 7 of these aforementioned settings. So this gives a little bit of context where NAMCS lies in our National Healthcare Surveys program. Next slide, please. So the goal of NAMCS specifically is to meet the need for objective and reliable information about access and use of ambulatory medical care services in the U.S. NAMCS was first conducted in 1973, where the visit data were collected from non-federal office-based physicians. In fact, these physician data maybe what are probably most well known about NAMCS. It's important to note here that the data collection from office-based physicians has continued throughout the years and itself has undergone some changes. Now, we're not going to get into all the details today about the physician data. However, a few milestones are worth noting here regarding NAMCS and the relevance to their survey's health center component. The first milestone I wanted to note was in 2006. Here, NAMCS began collecting data from community health centers. This is done by physicians who are sampled for NAMCS and provided care at health centers had data from visits that those offices collected. So any data from physicians practicing at these health centers was included within the office-based physician data collection files. This changed in 2012, however, when an independent sample of health centers was drawn. NAMCS now had a sample of office-based physicians as well as a separate sample of these health centers. Data collection was conducted among these two in parallel. In 2012, the health center delivery site was the sampling unit. For participating centers, up to 3 providers were sampled, and for each provider, up to 30 medical visits that occurred during a predetermined week were selected from which data were abstracted. Ultimately, for centers who agreed to participate, NAMCS would at most have data from 90 medical visits that were collected from a single calendar week, and for up to only 3 providers at that center. This went on for a while, and in 2021, there was a pretty big change. NAMCS began collecting data from health centers through the submission of EHR data for all visits during an entire calendar year, not just from that single week, and not just from a sample of providers. Next slide, please. So what led to the changes in data collection? Well, a few factors. First was that ambulatory care settings had become increasingly more diverse, and having data collection that reflects this is important. When NAMCS began, physicians were the only ambulatory care providers sampled. However, physician associates, nurse practitioners, certified nurse midwives, and other healthcare providers are all critical to the provision of ambulatory care. So providing for the care provided by these individuals, this results in a more encompassing view of ambulatory care in the United States. The use of EHR systems has also increased drastically in recent decades, including among health centers. So this has allowed NAMCS the ability to move away from using that manual abstraction for data collection to leveraging data submission capabilities of these EHR systems. And finally, telemedicine use now plays a bigger role in ambulatory care provision. Its use increased greatly during the COVID-19 pandemic, and it has continued to be an important aspect of ambulatory care. So accounting for these telemedicine visits is also important. As these factors in the relation to NAMCS were considered, the survey has moved forward consisting of 2 separate components, one of them for providers and one for health centers. So as you can surmise, the health center component of NAMCS is what will be discussed for the remainder of the presentation. Next slide, please. A little bit about the redesign. Next slide, please. So before going further, just for those who are unfamiliar, we quickly wanted to note what is mentioned or what is meant by when we use the term health center. We use this with our NAMCS health center component to include 2 types. First, it includes federally qualified health centers, or FQHCs. These are centers that meet the requirements set by the Health Resources and Services Administration, or HRSA, for their health center program and are part of this program. Second, it also includes FQHC lookalikes. These centers meet requirements for the health center program, but do not necessarily receive program funding. Both of these centers are included in our NAMCS Health Center. Next slide, please. For the sample design and methods of the survey, the NAMCS Health Center component draws a nationally representative sample of health centers. Again, this includes FQHCs as well as lookalikes through the 50 U.S. states in the District of Columbia. The visit data for the survey is completed and collected through submission of EHR data. The data collection takes place throughout the calendar year, and for each data collection year, visits to a health center are collected for that entire calendar year. The NAMCS Health Center component started with a sample of 50 centers in 2021, with an opportunity for replacement if a sampled center had declined. There's a longitudinal aspect to this sample, and over the past few years, the sample has grown. A bit more information about the sample will be on the next slide. Finally, I wanted to quickly mention that the NAMCS Health Center component also has linkage capability. As personal identifiers are collected, this allows for linkage to external data sources such as the National Death Index, the U.S. Housing and Urban Development Administrative data, and CMS Medicaid data. These linkages can further enhance the analytic utility of our NAMCS Health Center data. While the data linkage has occurred for several other surveys at the National Center for Health Statistics, including the National Hospital Care Survey, this marks the first time that we've been able to link data from NAMCS to external sources. Next slide, please. So I briefly mentioned the sampling earlier. In 2021, a primary sample of 50 health centers was drawn, as well as a reserve sample of 100 centers. So the participation target for this year was 50 centers. Recruitment began from the primary sample of health centers, and if one of these centers in the primary sample declined or were unresponsive during our recruitment attempts for a period of time, then a similar health center from the reserved sample was pulled and the recruitment of that center began. This approach resulted in 29 health centers participating in 2001 in provided data. A new primary and reserve sample were drawn for 2022, and a similar approach was used. However, in addition to the new sample drawn in 2022, those health centers who participated in 2021 were asked to continue their participation in 2022. This resulted in a total of 64 centers who submitted data and are included in the data file that year. This same approach was used in 2023 as well, with a new primary and reserve sample and solicitation for centers who previously participated in 21 and 22. A much more detailed description of the sampling procedures are contained in an NCHS Vital and Health Statistics report. And there's a link below at the bottom of the screen for the report. Next slide, please. Right, so the data collection process for the NAMCS Health Center component is a multi-step process. Through this process, NCHS works closely with participating health centers to have EHR data submitted. The process starts with an initial contact, continues with a facility interview, a testing and validation process, and finally, submission of EHR production data themselves. Next slide, please. All right, so for the initial contact portion, it begins with the phone call to the health center that was sampled and touching base with the representative of that center to see if they would be interested, willing, and able to participate. During this stage, NCHS explains the process of participating and gains agreement for participation. Health centers are also informed that by participating, they're eligible for a one-time setup fee or a reimbursement of up to $10,000 to help offset the costs of participation. Next slide, please. As for the facility interview, once a center agrees to participate, we conduct an interview with someone at the health center who can answer questions about the characteristics of the center. This interview is approximately 45 minutes. It was initially conducted over the phone, but has since moved to a self-administered web survey. That movement to a web survey occurred in 2023. The data collected during the interview is done so with the purpose of obtaining needed information that allows NCHS to create weights that can be used to make nationally representative estimates with the EHR visit data that are submitted by the center. Next slide, please. After the facility interview has been conducted, we move on to the testing and validation stage. When this process begins, NCHS works collaboratively with the center's health IT staff. Oftentimes, the center's EHR vendor is also part of the process. During this stage, an implementation guide designed for NAMCS and NCHS's other healthcare surveys is installed. The implementation guide acts as a template for what data elements are to be submitted to NCHS for the NAMCS Health Center component. It also specifies what formats that these data elements should be in when submitted. This is an iterative process often, and NCHS works closely with the health center until the data delivered meets the specifications of the implementation guide. Now, there are some instances where an implementation guide may not be able to be installed for a health center, but the center is still willing to participate. Good news is, if this is the case, NCHS is able to work and allow for custom data extract to be submitted, such that the center can still participate. Now, earlier I mentioned health centers who participate are eligible for a one-time setup fee to help offset any cost for participation. So after the testing and validation stage and passing, up to $5,000 of that fee is able to be provided with the help again offset any associated costs for completing this stage. Next slide, please. Finally, the last stage of the data collection process is the submission of production data. So this occurs once the testing and validation process is completed and passed. The center would submit production data. These are the EHR visit data that are included in the health center data files resulting from the NAMCS Health Center component. Coordination of this submission again occurs with health center staff and NCHS. Given the large volume of ambulatory visits throughout the year to health centers, these data submissions are large. NCHS therefore coordinates with the center to determine the number and frequency of data submissions during this process. Again, with the successful submission of production data, the remainder of the setup fee, again, of up to $5,000, can be requested to be reimbursed the participating center for any costs. Next slide, please. A number of data elements are specified in the implementation guide and collected as part of the NAMCS Health Center component. These include information about the patient, such as age, sex, race, ethnicity, and marital status, the start and end dates and times of the health center visit. It also includes diagnoses, lab tests that were conducted and ordered, medications, clinical notes, and a pregnancy flag that is created to flag maternal visits. And personally identifiable information is collected, and this is done so for the sole purpose of conducting data linkage. So rest assured that personally identifiable information is only used for linkage and never released or accessed by the public in any form. Next slide, please. All right, so where are we with the different data cycles? Currently, we've collected and released data from our 2021 and 2022 NAMCS Health Center component. We're currently in the process of finishing performing our disclosure risk analyses for the 2023 data cycle and expect to have this released in early calendar year 2025. Finally, we're moving towards the end of our 2024 data collection and expect that the file resulted from that collection will be released sometime near the end of 2025. All right. Now I'm going to turn it over to my colleague, Dr. Jill Ashman, to discuss the resulting data and products from the NAMCS Health Center component, as well as talk a little bit about some of its future plans. Jill?
Thank you, Brian. Next slide, please. The 2021 data are available as a restricted file in the Research Data Center. To access the data, a proposal must be submitted and approved, and there is a fee involved. In 2022, in addition to the restricted file, we were able to release a public use file. These data are available free of charge to anyone. Because of the huge volume of records in the entire file, we drew a random 5% sample for the public use file, and the weights were designed to allow for national estimates from the 5% public use file. Next slide, please. Okay, this slide displays the number of records in the full file in 2020. So in 2021, the file contained 3.5 million records. and which increased to 5.6 million records in 2022 and 9 million records in 2023. Next slide. So the page and location of the restricted data for NAMCS are shown here. Data dictionaries are available that describe the data available in each file, and there is also information about the process for submitting a research proposal. Next slide, please. Okay, the location of the 2022 NAMCS Health Center Component Public Use file is shown here. The data are available as SAS, R, and STATA files. You first navigate to the NAMCS 2022 questionnaires, datasets, and documentation page. At the top of the page to the right of the overview section is a list of headings on the page. The second one is the Health Center component, which is bolded here. When you click on that, it immediately brings you to the data and documentation section, which is displayed on the right-hand side of this slide. You can also just scroll to the middle of this page to see the NAMCS Health Center component data and documentation. Additional public use files will be displayed in a similar way. Each year of the survey gets its own page. We expect the 2023 NAMCS Health Center component public use file to be released early in 2025. Next slide, please. So I'm now going to talk about the preliminary data dashboards that we have. Next slide. So COVID-19 highlighted the need for more timely data. Moving to the collection of EHR data allowed us to collect data more quickly and made this dashboard possible. It is the first time we have had a dashboard or released preliminary data for health centers. Next slide, please. The dashboard contains weighted preliminary estimates so that we can release these estimates within 6 months of data collection. Currently, the dashboard includes 2022 and 2023 data. We expect to add the first half of 2024 data to the dashboard by the end of the year. The dashboards are interactive, allowing users to examine estimates by sex, age group, and race ethnicity. A module on maternal and reproductive health is currently available. 2 additional topic-specific modules are currently in development, one for respiratory conditions and the next for mental health condition. Next slide, please. Okay, here is a screenshot from the Visits to Health Centers by Diagnosis chapter module. The location of the dashboard is also displayed. This graphic shows the count of health center visits by race for mental health disorders. For all pages, estimates can be displayed as visit counts or visit rates. For this module, the health center visit page, all visits can be displayed, or diagnosis-specific visits by diagnosis chapter can be displayed. And finally, the groups that can be displayed include total visits or visits by age or sex or race ethnicity, with Hispanic, non-Hispanic Black, non-Hispanic White, and non-Hispanic Other as the available categories. Information can also be displayed as a chart or a table. Next slide, please. So this graphic displays the page from the Maternal and Reproductive Health module. It shows the count of any visit related to maternal and reproductive health. The 4 maternal health measures include any reproductive or maternal health visit, prenatal visits, postpartum visits, and other reproductive health visits. Once again, estimates can be displayed by visit counts or visit rates. And the groups to choose include visits by all female patients between the ages of 12 and 55 years old, maternal visits by race ethnicity, and maternal visits by age range, which is roughly decades, 12 to 19 years old, 20 to 29, 30 to 39, and 40 to 55 years old. I do want to reiterate that updates are still ongoing. We expect to update the dashboard twice a year, adding data in June and December, so check back to see more data. Next slide, please. I'm now going to talk about the data linkage projects with NAMCS Health Center component data. First, I want to acknowledge that the HHS Office of the Secretary Patient-Centered Outcomes Research Trust Fund provided the financial support needed for these linkage projects by providing funding in both fiscal year 2021 and fiscal year 2023. Next slide. So we had never been able to link external data to NAMCS because until now we had never collected PII. With EHR data, we are able to collect name and social security number and use that information to link to external data sets. I want to again reiterate that name and social security number are never shared publicly. They are only used to link records to external sources, and then they are stripped from the file. Next slide, please. So NAMCS Health Center component data will be linked to the National Death Index by the end of October and linked to the Housing and Urban Development data in December. Linkage to CMS Medicaid data will be available next summer. All of the linked data sets will only be available in the Research Data Center. Next slide. Okay, now I'm going to discuss current and future plans for the NAMCS Health Center component data. Next slide. So we are currently collecting 2024 data, and plans are underway to continue data collection in 2025. We are currently processing 2023 data. We expect to release restricted and public use files by early 2025. We are working to standardize the format of additional variables, including vitals, lab tests, and medication, and hope to add these variables to files in the future to supplement the variables already available, including demographic information, visit information, and diagnoses and conditions. We hope to also explore unstructured clinical notes to see if natural language processing and machine learning techniques can be used to extract additional information from clinical notes. Next slide, please. As mentioned previously, we are both expanding and updating the dashboard. By the end of the year, we expect to update the dashboard with preliminary data for the first half of 2024. Expansion of the dashboard is also under development, and 2 new modules are being developed. As mentioned previously, data linkage work is ongoing, with linkage to the NDI and HUD by the end of this year and CMS data by August of 2025. Next slide, please. So we have already started publishing articles and reports using the NAMCS Health Center component data. The technical documentation for the public use files, the document on the left, is a very important document to read if you are interested in using public use files or RDC files. The middle document is a methods report and explains sampling and data collection. The third publication is a Health eStat, our first publication showcasing the data. It reports visit rates for adolescents and adults with mental health disorders, substance use disorders, or both disorders. 2 additional reports are being released, including a methodological scientific article discussing the use of a setup fee to encourage survey participation and electronic health record submission for the NAMCS Health Center component, and an upcoming NHSR report describing visits to health centers among adults in 2022. Next slide, please. This next set of slides displays web links to access important information about the NAMCS Health Center component, as well as information about other national healthcare surveys. Next slide, please. So if you'd like to take a screenshot of this page, it lists several resources for the NAMCS Health Center component available now, including the link to the 2022 public use file and documentation, the dashboard, information about NAMCS RDC files, and linked data, the general page to the RDC, and the participant page designed specifically for participants at health centers. Next slide, please. Our family of surveys are displayed here, and the link at the bottom of the slide takes you to the main National Healthcare Surveys page, which includes descriptions of each of the surveys listed here. Next slide, please. This last slide displays our contact information. We can be reached by email or phone, and you can also direct any questions to the CDC main number, and the question will be directed to us. Finally, thank you so much for your time and attention. We really appreciate that you took time out of your busy day to join us today.
Thanks, Jill. So we still have some time, so we're going to enter a question and answer session. Is the remaining time allows, Jill and I, and along with some of our other wonderful colleagues we have on the line from the Division of Healthcare Statistics, will be addressing questions from the Q&A box. Questions can still be submitted at this time through that feature as well. If we don't get to a question or comment today, or if something is maybe thought up after the webinar, again, you can direct that question to us to the email address that was just displayed on the last screen. And that was ambcare@cdc.gov. All right, so I'll turn it over to my colleagues who are working the Q&A box there for us.
Good afternoon, everyone. So we have our first question. So the question states, with the redesign, will users be able to combine data with the NAMCS or from the NAMCS Health Center component with the regular NAMCS provider component to compare visits at CHCs versus those at office-based providers? So
yeah, all right. Thank you for the question. Good question. Yeah, and with the 2021 redesign, it was definitely a big change. So that we are not able to combine from files, health center files, from 2012 to 2020. So unfortunately, that's not the case. But moving forward, again, with 2021, there's a similar design. So, using that data moving forward for trend analyses, things such as that would be able to be done.
Hi all, I have another question that we can bring to the presenters. What are the differences between the restricted and the public use files?
Thanks. Yeah, a few things. The large thing is, as Jill mentioned earlier, is the restricted files have the full millions of records. So that's one of the big changes. Just the amount of data can create issues sometimes with folks running just with memory space when they're running statistical analyses. So that public use file has a 5% sample from the full restricted file. That allows the same analyses to be done. Those public use files can still be used to make nationally representative estimates as well. There's weights designed specifically for those. So in the same time, again, the restricted files are available through the RDC as well if folks are interested in accessing those. We do too, obviously, with all of our surveys at NCHS, the public use files sometimes might not have the same level of detail for certain variables. For example, some diagnoses codes that might be a little bit more rare, not appear too often, would not be included in those public use files. And that's, of course, just to ensure that we protect, any potential identification of, from a health center visit in this case. So there may be a little bit less detail for some of those data elements as well, is another difference for those files.
So we have another question about how we select the 50 or 100 or so participating health centers, because the assumption is that we're only producing national estimates. So I think, well, if you don't mind, we have a sampling paper that goes into detail about how we select our sample. But essentially, we use census, region, and division information to select our representative sample of health centers. And then from there, we have a primary and a backup sample. But I think the sampling paper that might be linked, where we can link that in the chat already, should go into detail about how we sample our health centers.
Yeah. Thanks, Joy. And just that report is a wonderful resource there. And just one more thing to note, I know when discussing the sampling early on in the presentation, I mentioned that, with the primary sample, if a center, is not able to participate, we pull from the reserve sample that was drawn for that year for a similar health center. And by similar, it sort of leads to what Joy mentioned. A center that's in sort of similar geographic region has some of those same characteristics. So again, the report, though, is a good, if you want to get into the nitty gritty and the details, the report's a great place to take a look.
We have another question to raise. You mentioned that health centers who participate can get reimbursed for up to $10,000. Can you explain a little more about this process?
Sure. Yeah. Well, the participation with NAMCS Health Center component, just from our experience working with some of our other healthcare surveys, as well as consulting some of our colleagues at HRSA and elsewhere, it does take a little bit of cost to sort of not only have the staff available to work and get the data submitted, as well as the installing the implementation guide into the EHR system. And again, that implementation guide is in essence an electronic template that's used to submit data. So in recognizing this, to help encourage health centers to participate, as well as to help offset potential costs. For those health centers that participate for the first time, there's a one-time opportunity to request up to $10,000 as sort of a reimbursement, if you will. So that is the first year that a health center would participate, going through the process. Passing testing and validation, as I mentioned, they could put in a request for up to half of that $10,000, and then the second half could be requested after the production process. That is a one-time fee. So, for example, participating and getting that fee in 1 year, we ask that the health centers continue to submit data and participate. But that fee would not, if they continued into additional years, that fee would only be available that first year. And thankfully, I know that we've had some wonderful centers participate, and the continuation of submitting data it is rather high once after that initial participation. So we're very thankful for those health centers that have participated.
So we have another question. Is the NAMCS Health Center component related to the UDS that health centers report to HRSA?
All right. Thanks, Joy. Now, it's a good question. So the NAMCS Health Center component is separate from the UDS, and that's the Uniform Data System. So that's something that the Health Resources and Services Administration, or HRSA, has that health centers and FQHCs and FQHC lookalikes will report to. So we're a separate data collection. And I know, there's, I don't want to speak too much, there's sort of resources available to kind of look at the UDS, I know, on that, but they are different systems.
Thanks for that, Brian. One more question to raise. Are there any examples of the types of analyses that can be conducted using the NAMCS Health Center data files?
Yeah, another good question. We do have as Jill mentioned, there was a report that came out looking at using our NAMCS Health Center component data to look at mental health and visits related to mental health disorders, substance use disorders. We also, I believe, in about 2 weeks, I know by the end of the month, there'll be a report coming out that that uses NAMCS Health Center component data to give a little bit of an overview, sort of a summary of the data, and that sort of gives a good, example as well of some of the analyses that could be coming out. I know also too, again, those data files just, they are available for 21 and 2022 and then near future 2023. So those are, folks can also grab those, take a look and look through the technical documentation, see what's available and do their own analyses. So we're looking forward to seeing, some of the what comes out of those data files from folks outside of NCHS as well.
I'd also like to say the dashboards are also give a good summary of some of the data that are available, like the just how many diagnoses there are for mental health conditions or circulatory conditions. So the dashboards are interactive, and so you can look at them, lots of things through the dashboard too. So we encourage you to check those out.
Again, the Q&A is open. Those were the questions that we had in the question box.
Thanks, Joy. All right. Well, I guess just in closing then, thanks so much for taking time today to join us. We appreciate the attendance as well as the questions that were submitted for today's webinar. So just to let everybody know, a recording of this webinar along with the slides will be made available and posted on the NCHS website in a few coming weeks. So thank you again very much, and I hope everybody has a good rest of the afternoon. Bye-bye.